our last speaker in the session. Not last but not least, Helena. Thank you for hanging in there. Helena Williams. Helena is a postdoctoral fellow at KU Leuven and also at King's in London. And her PhD is related to machine learning, artificial intelligence. And so Helena's not a clinical doctor when we get to the questions, but she is a real talent in terms of AI and so on. And she's been working with the antidepressant, particularly in the group in Leuven, looking at AI type solutions to look at the pelvic floor. I think it's great because I've always looked at the pelvic floor ultrasound, find it a bit tricky. So anything that can help, I think, will be marvelous. So I'm going to hand over to you, Helena, and then we can talk about things. Over to you.
Hi, I'm Helena Williams and I'm a postdoc at KU Leuven. I've spent the last 8 years developing AI technology to assess pelvic floor ultrasound images. And this presentation, I'll talk about pelvic floor injuries, mainly from childbirth, and the role of ultrasound and the key question of accessibility, not just whether this technology exists, but who can realistically use it and how can we make it more accessible with AI. These are my conflicts of interest. Some of the research has been supported by GE Healthcare and some of the AI algorithms are now in the sonopelvic floor platform. We'll first start with why pelvic floor injury matters clinically, especially around childbirth. Then we'll talk about how AI is already here and already in use, discussing then the gaps of limitations, mainly being around acquisition, and finally look at how we might harness AI and pelvic floor ultrasound imaging for a better future for women's health. So pelvic floor injury is most commonly caused during childbirth. This is a slide of an anatomy, and you can see the pelvic floor muscles of the levator ani muscles surrounding the urethra, the vagina, and the rectum. You can also see on the right the anal sphincter, which are a group of muscles that allow for defecation and also maintaining continence, and they surround the anal canal and the rectum. You can see them here. So the job of the pelvic floor is to support the internal pelvic floor organs such as the bladder, the bowel, and the uterus to make sure that they continue to function properly and are in the right position, and it allows for defecation, urination, maintains continence as well as sexual function, and also helps aid childbirth itself. So one key injury which can be caused during childbirth is levator ani muscle avulsion. 3D ultrasound, the transperineal in this case, can be used to visualize it, and studies show that it can occur in about 15 to 30% of vaginal deliveries, and this injury appears to link childbirth and the woman later potentially developing prolapse. So you can see here the ultrasound image, there is a clear detachment of the levator ani muscle from the pubic ring. Now it's associated with higher maternal age at first delivery, might increase the risk of someone developing levator ani muscle avulsion, and there's been research discussing that the use of forceps for assisted delivery can also increase someone's risk of levator ani muscle avulsion. Now, the reason this matters for today's talk is that these injuries are often occult. They're not always obvious on clinical examination, but they can be seen and are visible with imaging. And that's what makes access to ultrasound really central to detection, understanding, and triage of levator ani muscle avulsion. Regarding the anal sphincter, this can also be injured during childbirth, and it's quite common that it also leads to fecal incontinence. So it's roughly estimated that there'll be at least 1 in 4 women who will have some type of anal sphincter injury after the first vaginal delivery. And again, unfortunately, some of this is actually missed under clinical examination, and research suggests that around about 1 in 5 injuries are actually not recognized at childbirth, but can be identified with transperineal ultrasound imaging. So pelvic floor injury may present as pelvic floor dysfunction immediately after birth or months to years later. There's also a lot of women who may have pelvic floor dysfunction without pelvic floor injury due to childbirth. Pelvic floor injury can really affect women's continence, prolapse, pain, sexual function, as well as quality of life and body image as well. So pelvic floor dysfunction is extremely common. In our research, we found that nearly 3 in 4 women a year after their first vaginal delivery experience at least 1 or more pelvic floor dysfunction symptom that includes incontinence, prolapse, sexual dysfunction. We also, as I mentioned, see that injury may be missed with clinical examination, and ultrasound really allows you to assess it more objectively. As well as that, we know that at least half of women who experience symptoms never seek care, often due to stigma, embarrassment, or believing that their symptoms are normal. So if we want to improve the education to women, we may expect to see more asking for help in the future. And finally, the prevalence is also expected to rise. So with aging population, obesity, lifestyle factors, women having their first child potentially later on in life, all of these aspects might increase the risk of pelvic floor injury or pelvic floor dysfunction, and there's a lot of research to suggest it will be rising in the future. That's why we need new tools, and AI could be one of them to help. So we have a clear pathway from how childbirth can lead to structural injury, which can lead to pelvic floor dysfunction symptoms, often with a delay or sometimes immediately after. Imaging is what allows us to see that missing link and to be able to assess if someone has trauma, to potentially allow for better caregiving and preventative measures in the future. So in most of, I'm speaking now from Europe, we don't routinely image women postpartum, their pelvic floor. What usually happens is a woman may present with symptoms and she may be referred to pelvic floor physiotherapy. If symptoms persist and she goes back to the GP, she may eventually receive a comprehensive pelvic floor assessment. Now, that assessment is normally multimodal. It contains patient-reported outcome measures, so validated questionnaires based on their symptoms, clinical examination, and also imaging for anatomy and also function. We're talking in this case about ultrasound imaging. Specifically, I work mainly with transperineal ultrasound imaging, but endovaginal and endoanal are also accessible, as well as MRI. Now, ultrasound plays a really key part here. It allows for dynamic assessment, so you can see the pelvic floor function in real time. It allows for 3D visualization, which is quite key when you want to see certain diagnostic planes like the one shows here of the anal sphincter. You can only really access this by manipulating the 3D volume of the anal sphincter and pelvic floor system. And it also allows for then the assessment of both function and anatomy of the pelvic floor. Ultrasound also benefits from being lower cost than imaging like MRI. It's quite repeatable. There are many guidelines that's been showing the standardization of the acquisition and analysis of ultrasound imaging. And in pelvic floor imaging, we commonly use transperineal ultrasound in our university hospital, but you can also use endoanal and endovaginal probes depending on what you're looking for and what probes you have available to you in clinic. Now, despite the advantages, there are obviously limitations of manual image analysis. Image analysis of pelvic floor requires a substantial level of expertise and training. It can take a lot of time, which might stop it being available in certain clinical practice. There's also an amount of human error that people can make mistakes, people can have bad days and misinterpret the image or acquire it badly. And there's also a high level of intra-observer variability. So a novice and an expert obviously have a bigger difference, but even between the same level of expert, they might come up with a different analysis of the patient's ultrasound depending on how they interpret the image. So what is the current reality of ultrasound access for pelvic floor injury assessment? Well, high quality assessment is capable and possible, but mainly in specialist centres. For community and postpartum clinics, they may have limited or no imaging available whatsoever. And it might be due to advanced ultrasound systems being costly or a lack of experts and specialist training and time for them to perform those tasks. Or it could just be dependent on the infrastructure and resources available to the clinic. Now, with AI, we're not looking at solving the cost or also the infrastructure and resources aspect, but in terms of specialist training, accessibility, that is something that we can look at tackling with AI. So how AI can help is that it's actually already doing quite a good job in standardizing plane detection, standardizing measurements that can be used as clinical biomarkers, and potentially flagging of suspected injury. So these are some examples of tools we've developed at KU Leuven to extract the plane of minimal hiatal dimensions, which can be used to assess the levator hiatal area, which is an indicator for pelvic organ prolapse and hiatal ballooning. We then have also identified the levator avulsion by measuring this levator urethra gap following the standard protocols outlined by Dietz. And regarding the anal sphincter, we have also automated this plane selection. So we give a transperineal volume of the anal sphincter, and the AI then can slice it accordingly. So you can see the anal sphincter from the caudal end to the cranial end of the external anal sphincter and internal anal sphincter for manual analysis. And finally, we have also worked on then automatically assessing where there is a defect on the external anal sphincter to feed that back automatically to the user. So AI is already analysing images quite well, and this is quite a big proportion of 3D transperineal ultrasound imaging analysis of the pelvic floor system and anal sphincter that has already been automated, and several of these are already available on tools from several ultrasound providers. So what AI is solving is it's really reducing that reliance on highly experienced operators by standardizing assessment and also reporting, as well as saving time. But what it's obviously not doing at the moment, because it's mainly on more high-end devices, is that it doesn't help reduce the cost of machines or solve the workforce shortages that might be affecting more community-based settings. Now, analysis is not the whole story. AI is also really needed to fix poor acquisition. So ultrasound is a handheld type of imaging. You really need a good level of skill to get a good ultrasound image in the first place to do your assessment. And at the moment, most of the literature that we have reviewed has been based on the analysis of these images and not helping you acquire a better image. Now, this is really important because for AI, if you give rubbish in, you will get rubbish out. And the key areas that could reduce the sort of accuracy of assessing a patient is if you have poor probe placement, if you have shadowing and artifacts, or if you're actually in an incorrect plane as well. And big hint is that if a clinician struggles to analyze your image, an AI probably will too. So there's some suggestions. We've done a little bit of work on this at KU Leuven, but there's still a lot more to do, is we could potentially use AI to help guide the probe placement of ultrasound imaging to make the acquisition more accessible. And we could also potentially let the user know, look, there's an artifact here, you can see a reverberation, there's a reflection which is causing this acoustic shadowing that basically skews sort of the caudal or the cranial end of the external anal sphincter here, making this volume not usable for assessing anal sphincter injury. This would then allow better access and more access to mid-level providers, for example, in postpartum clinics and community settings, to sort of start triaging and assessing people's pelvic floor structures as a more common practice. So at this point, I hope we all believe me that we say that AI exists, especially for pelvic floor ultrasound imaging. There are clear examples, but there are also very clear gaps. Many tools are validated on potentially narrow populations, and some I've seen on literature have also excluded severe pathology, which is a huge problem because pelvic floor care is probably very important that it detects it very well on those with severe injury and severe pelvic floor trauma. And if they're excluded from research data sets, we don't actually know how well these AI algorithms will be on detecting them in sort of use cases in clinic. There's also a lot of limited data sets in terms of sort of race, ethnicity, age, and geographical location. And we need to make sure that AI performs for all patients and not just the very few that were used in their training data. As I also mentioned, acquisition support is still very limited, if not at all, within clinic using AI. So without better guidance and feedback during scanning, accessibility will always remain limited, regardless of how good the analysis tools look. If you can't have a good ultrasound image that contains the information that you need to assess, then there's no point of having a really great analysis tool. There is also a huge trust gap, partly due to limited transparency of the research of algorithms from industrial vendors and also clinical validation. So I think an important part is actually you as the clinical sort of if you're a clinical researcher, start to look at independently validating these AI tools that are available in your clinic to see how they perform on new data. And I think this is really important to then increase adoption, increase trust, as adoption is as much as a human challenge as a technical one. So clinicians need to understand when the tool fails, what the tool does well, how they can intervene, and then trust comes from transparency and control and not fully relying on the AI tools. So that requires a communication between the engineers, between the companies, and between clinicians, and making sure that everyone is very aware of the bottlenecks of using AI for pelvic floor ultrasound imaging. And finally, accessibility. If we only train and implement AI on high-end devices and machines, we will only serve high-end centers and potentially a certain type of population. True accessibility means developing tools that work on more affordable systems, including potentially lower image quality without compromising the clinical assessment of that patient. So what future could this lead to? I am really strongly believing that it can reduce expertise burden with standardized analysis and allow for more equitable care if we make sure that the data sets are more general and support a sort of wider demographic of the population. Secondly, what I'm very excited with is earlier triage. So AI supported pathways could help the non-specialists identify women at risk sooner and direct them to care and support others with potentially conservative treatment, or just so they have more information for following pregnancies and births that they have a pelvic floor trauma or injury. But that's probably reaching a bit too far. There's still a lot of research and evidence that has to be done before those decisions can be made. And third, big data insights. With enough scale, AI could potentially reveal new predictive patterns, who may need surgery, who may recover naturally, who benefits the most from physiotherapy, and how many physiotherapy sessions. All of this might be more obvious when we assess more patients, more data, and AI can automate all these scans for us automatically. Now, why this matters is that pelvic floor dysfunction, as I mentioned, is expected to increase in prevalence. And at the same time, maternal health is now sort of under a looking glass as a priority within women's health, both because it affects women massively in the long term, physically and emotionally. And this creates a real opportunity for better care and better women's health and longevity. So the key takeaways of today is that pelvic floor injury is common. It can contribute to pelvic floor dysfunction, and symptoms can have a huge impact on quality of life and body confidence. Ultrasound is a way to assess pelvic floor injury and trauma, and AI can make this more standardized and more accessible, especially when we add in acquisition guidance and put these tools on more affordable ultrasound devices. Finally, when implemented thoughtfully, AI can enable early triage and I believe equitable care with new insights at scale, which is very exciting. So thank you very much for listening, and I hope you enjoyed.
Oh, thank you. What an interesting talk. I always like hearing you lecture. I know your passion is democratization of ultrasound, really, and trying to find a rollout of these tools in settings which currently are underserved, I think is a fair comment, I think, because we've talked about this before.
Yeah.
What are the barriers there then? I mean, when you have if you're looking at AI, obviously with segmentation measurements and you're getting guided plane acquisition seems to be what's going on. How do we, what are the limitations of, for example, handheld devices in actually achieving this? I mean, what level of machine do you require? Because currently, obviously, understandably, manufacturers are investing in these things, trying to develop and putting them on their high-end machines. This is how it always goes, and then it percolates down. However, I would argue, especially for this audience, we want to find a way of getting this sort of AI helping people in settings where perhaps they don't have access to people who like Jan depressed or whoever. What's the story here? How do you see it developing?
Yeah, I think the difficult is a really good question. I think the difficult thing is that a lot of the pelvic floor ultrasound protocols that we have at the moment are based on also 3D ultrasound imaging. So even if you go to sort of a 2D handheld probe, at the moment, handheld probes are 2D. So even to look at those standard diagnostic planes to assess the anal sphincter entirety and where there's a defect or it's intact isn't actually possible with the type of images that are required on handheld ultrasound. So it also requires working with those leaders in ultrasound imaging to see what is the best alternative with a cheaper device. Can we do these comparison studies against 3D and then also look at like integrating AI on those tools as well to help with the acquisition? The thing that makes it difficult with handheld 2D is that then also getting in the right position is going to be a lot more difficult and require a lot more highly skilled and technical AI algorithms to assess that. Whereas when you have a 3D probe and a 3D volume, the algorithm can really do that plane extraction a lot quicker without needing sort of intervention. So it requires, working with the clinicians or researchers and seeing what other proxies we can have for sort of 2D scanning and hoping that 3D handheld probes is also something of the future.
I suppose in some ways, if one could demonstrate utility, that it makes a difference, and that therefore, if one could deliver that diagnostic capability into the hands of people, that would then stimulate potentially the investment to do that. Because in a sense,
Yeah.
you're trying to take a punt on two levels here.
Yeah.
Can you do it technically? Actually, is there any point?
Yeah.
I think
Yeah.
that currently must be an issue. My understanding is that it's not really CPU power or whatever that's blocking that. I mean, you can build these into machines, and I think
Yeah.
manufacturers at the moment don't tend to put their biggest chips in there anyway. So I'm sure it could be done, or presumably, maybe you can tell me, and can you do it from the cloud as well and communicate to the cloud and actually do your computing and just move away from the convention that the box is what matters. The software is being delivered from a different situation.
Yeah, from what I am aware of now, like running the actual algorithm on the new data can be done without much computational hardware requirements. So it can either be done through the cloud or also locally. I think GE's, all of their AI algorithms are on the ultrasound platform, and to my knowledge, it isn't as much of a requirement in terms of GPU, CPU as what we originally were working on to actually train those models. For handheld as well, I know Clarius have a lot of AI tools as well. And then I think that again, as you say, is probably on the cloud and then is enough power for it to be used in the clinical settings, which is good.
I mean, I think for the ultrasound manufacturers, this is the challenge that I think, anyone can make a box. I think it's going to be the manufacturers who have the software. I think, I don't know, I mean, GE is probably online here, but I presume when they're looking ahead, they see themselves as being almost brokers of software, which they'll license onto their devices and things like that, not just purely doing their own stuff. There's a question here. I don't know if you think
Yeah.
if it strays too much clinically, but I know you know lots of clinical stuff. You probably do the job anyway. But anyway, can postpartum ultrasound identification of pelvic floor muscle injury serve as a prognostic marker of a long-term dysfunction following delivery? This plays into another question of kind of, ideally you'd want to, just as a second question around that really, um, because surely the ideal thing is basically do a scan straight after delivery and see if you can actually find the problem and deal with it. And of course, that's not so easy, but I think they're
Yeah.
linked, aren't they, in a sense? So could you say something about immediate postpartum ultrasound, and then whether you can actually use that to guide treatment then, and or whether it then has long-term implications?
Yeah, I think there's a lot of information that can be seen from these scans. So indeed, there's not always a strong link, or there hasn't been enough funding and research and time to establish this. Pelvic floor dysfunction is a functional problem as well as sort of a structural problem to the muscles. So it's very hard to say that if you have this type of injury, you'll end up having this. But there's strong links between anal sphincter injury and fecal incontinence. There's links between levator avulsion and then prolapse and hiatal ballooning from research from Dietz, Hans-Peter Dietz. So there are a lot of links, and it's also about finding the right time after somebody has given birth to scan them. Personally, if I gave birth after like 6 months or whatever, I would want my pelvic floor scan to know for future pregnancies if there was a structural injury to my muscles. I think that's useful, but indeed, there's not that like long-term research yet to say that woman with that injury will have pelvic floor dysfunction in 10, 20 years' time, because it's not just birth, it's BMI, aging, family history. It's such a multivariate functional problem that can happen. But I think it's just more information and piece of the puzzle that is important for women to know in sort of better advocacy of themselves as well.
Because it's going to be interesting because we're going to hear later on this evening, just want to highlight the session between 6 o'clock and 8:30, where Christoph Lees is going to talk about point of care ultrasound on the labour ward. And so obviously, if you went on a labour ward trying to use a scanner not that long ago, everyone would look at you and say, what the hell are you doing? But now there's an acknowledgement that actually is adding value. And obviously, so with that sort of bringing ultrasound onto labour ward, it would be great if we could evaluate the pelvic floor, because the underinvestment is shocking when you look at the consequences.
Yeah.
I mean, it's unbelievable actually, because it's amazing how in gynecology some things are invested in and other things, despite having an awful impact on people's lives, they're completely just ignored almost.
And if I may, the other thing, I think this is such an interesting idea, because one of the big things is underdiagnosis of anal sphincter injuries at the time of birth. And we know that if we suture, if we recognize and do, a really good repair, that may reduce the impact of these problems. So actually, screening at the time of delivery is so interesting. Is it going to be better than just a clinician or a clinical the birth attendant assessing the perineum themselves.
Yeah, we did a sort of systematic review, and we saw that ultrasound findings were detecting about 1 in 5 more anal sphincter tears than, so it was about 25% or 20% were actually missed, and with ultrasound you could see the tear, because sometimes it can be quite deep and not be seen superficially. So yeah, I definitely am all for ultrasound imaging, and it can share a lot more light on these injuries that are being missed.
And just a final question, because going back more to the sort of AI side of things. I mean, how are we going to get over this? I mean, it's very hard to do these projects very often and acquire data and so on. So if you
Yeah.
look at the models you're using, obviously they've been, what populations are being studied? Are they largely European, in Belgium, that kind of type scenario? Or how will they potentially apply, even if we did apply them in a completely different setting? Say, for example, if we took the same thing to Malawi, do you think they're going to work, or do you think we have to be repeating these studies and finding data elsewhere?
I think we definitely need to validate them in in a wide range of populations on ethnicities and race, and make sure that there's no performance drop there. It's really important that we make sure it performs equally. I don't know if it'll perform equally as well. There's a lot of research looking in other areas where you see a performance drop. And it can also be due to the clinic. So if we have a lot of data from pelvic floor dysfunction patients, those tend to be a lot older, and the tissue looks sometimes very different when they've gone through surgery than younger populations. So it really needs to be validated on lots wide range of populations and demographics. And then we understand, do we then need to actually retrain this model or improve the precision to use it wide range in clinical applications.
Helena, we're going to have to finish
Thank you.
there. Thank you, and really interesting work, and we look forward to seeing more of that. Really, I think it's such an important topic, and if the ultrasound manufacturers are listening, invest in this, because it's. I mean, the thing is, millions of people have babies. Not that many people get ovarian cancer in the great scheme of things. So the market is there to invest in, is all I would say.
Yeah.
Helena, thank you.
Thank you.
So it means we're going to close this day of early pregnancy and gynecology now.